Dear friends, hi. Today I will present 4 different cases of acute aortic pathology, including 2 cases with a so-called crescent sign, 1 case with contained or impending abdominal aortic rupture, and 1 case with definite abdominal aortic aneurysm rupture. So let's start from with the first case, which is a contained or impending abdominal aortic rupture. This is a male patient, 61-year-old, with known abdominal aortic aneurysm, worsening abdominal pain since few days ago, radiating to back. The patient was hemodynamically stable. The findings: there is a large infrarenal abdominal aortic aneurysm with significant mural changes. There is edema, mural edema, thickening, and there is some hyperenhancement in these regions. And of course, there is fluid surrounding the abdominal aortic aneurysm. It is worth to note that there is no diffuse large retroperitoneal hematoma. There is no significant irregularity of the contours. There is no significant blurring of the retroperitoneal fat, and the contour of the iliopsoas muscles are relatively well defined. So in this case we have a contained or impending abdominal aortic acute pathology. Now let's go to the second case. This case is a male 68-year-old with acute onset of central abdominal pain radiating to back, and the patient was hemodynamically unstable. The findings: this is a typical retroperitoneal hematoma on a background of a quite large abdominal aortic aneurysm. Here is a rupture, and the differences with the previous cases is that there is clear retroperitoneal hematoma, significant irregularity of the contour of the fluid, which is relatively hyperdense. There is a extension of the hematoma posteriorly, and the contour of the iliopsoas muscles are significantly obscured, particularly on the left side. So this case is a typical abdominal aortic aneurysm rupture. I would like to go back to the first case, which is a contained or impending abdominal aortic rupture, and I would like to make some comments. Identification of impending or contained rupture is very important because these patients are at high risk of frank rupture, but can generally benefit from a more thorough preoperative assessment followed by urgent surgery. And it is noted that the classical triad of pain, hypotension, and pulsatile abdominal mass due to rupture into the retroperitoneal is only seen in around 25 to 50% of the cases. We can also call it a chronic rupture, which may escape detection for about weeks to months. And in this case we have a sealed aneurysmal rupture or spontaneously healed aneurysmal rupture, or abdominal aortic aneurysmal leak. Now let's go to the third case, which is less critical, and here is a female patient, 59-year-old, with acute onset central abdominal pain radiating to back, pulsatile mass in the abdomen, and the patient was hemodynamically stable. The findings: we can see the infrarenal abdominal aortic aneurysm without rupture, but there is an endoluminal thrombus which shows a very thin and very ill-defined hyperdensity, representing the so-called crescent sign. It is this slightly wide linear structure into the thrombus here in the axial views, here in the sagittal views, and here in coronal views. It is very ill-defined, and we must pay attention to identify it, but it is very important. The crescent sign, this high attenuating structure within the thrombus, actually represents an acute hematoma within the thrombus. It actually represents fresh blood, which first accumulates itself into the mural thrombus and later can penetrate the aortic wall. Similarly to that case, I will show you our last and fourth case of a crescent sign in an abdominal aortic aneurysm. And here we can see it probably better. This is exactly where it is located. We can see the abdominal aortic aneurysm, the endoluminal thrombus, and the crescent sign is exactly here. This line here and here. Dear friends, thank you very much for watching. If you find my videos interesting and useful, please drop a like and consider to subscribe so you will not miss my next interesting case in radiology. And of course, any questions or thoughts are welcome in the comments. Thanks again for watching, and until the next time.